If a patient has failed a topical treatment, but they may not be interested in systemic therapy, they don't want a biologic or they don't want an oral therapy, phototherapy still is a good option for these patients. In particular, I like it for patients with moderate disease. So moderate disease would be between 3 to 10% body surface area. So we do say that phototherapy serves as a reasonable and effective treatment option for patients requiring more than topical treatments, but also wishing to avoid systemic medications, or if they simply seeking an adjuvant to a failing regimen.
That's Dr. Jashin Wu, and this is Dermatology Weekly by MD Edge, where we bring you news and developments in dermatology and peer-to-peer conversations with dermatology experts. I'm the voice of MD Edge Podcast's Nick Andrews. Today, phototherapy is a viable option for many patients with psoriasis. Dr. George Han speaks with Dr. Jashin Wu about the recent national guidelines from the American Academy of Dermatology and the National Psoriasis Foundation on phototherapy, particularly narrowband UVB. They discuss treatment advantages, potential side effects, combination regimens, and patient reimbursement for at-home phototherapy. We're also bringing you the latest from this week's Hawaii Dermatology Seminar. There, we spoke with Dr. Hilary Baldwin about a concept in the infectious disease literature that can help slow resistance to antibiotics that are used to treat acne. Dr. Jashin Wu shared his preferred approaches to controlling hyperhidrosis. Full disclosure, the Hawaii Dermatology Seminar and MD Edge are owned by the same parent company. Remember, if you have feedback or suggestions, you can email the show at podcasts@mdedge.com. We appreciate ratings and reviews on Apple Podcasts. We take them seriously and incorporate them every time we approve the show. We'll be right back after this short break. The mutant selection window. It's an antibiotic resistance concept described in the infectious disease literature nearly 2 decades ago. So, why is it relevant now, especially to antibiotic treatment in patients with acne? At the Hawaii Dermatology Seminar, Dr. Hilary Baldwin of Brooklyn, New York, talks about the mutant selection window with MD Edge editor Elizabeth Meshkati.
A year ago, a new concept was brought to my attention and the attention of several of my colleagues who are all considered part of the acne mafia, if you will, which was that of the mutant selection window. This had been published in 2003, and although it was published in 2003, none of us had ever heard of it. And we were all people who were going out and discussing the problem of antibiotic resistance, particularly in acne and rosacea, where we utilize oral antibiotics for conditions which are basically not infectious in nature. So the CDC asking for antibiotic stewardship were all but pointing fingers at us as dermatologists who are using antibiotics for non-infectious reasons, which is a no-no in 2020. So much to our dismay, this publication and others like it came out in the early 2000s in the infectious disease literature, and it was not something that managed to permeate into the world of dermatology. There were maybe 15 of us in the room at the time, and we were all just dumbstruck. We were just, it literally blew our minds and changed the way in which we thought about antibiotic resistance moving forward. So the bottom line is the mutant selection window is the space in between the MIC, which is the minimum inhibitory concentration, and what they call the MPC, or mutant prevention concentration. So there is a very low dose of an antibiotic, which is the MIC. Lower than the MIC, it won't work at all. At the MIC, it's going to kill the susceptible organisms in the population that you're talking about. Then at the very high end, the MPC, the mutant prevention concentration, is the high end of drug concentration, which will kill not only the selective bugs, but the mutants as well. So clearly, you would choose to use a drug that exceeds the MPC, the mutant prevention concentration, if you could. Why might you not be able to do it? Well, maybe the drug isn't safe at that concentration. For every drug, there is a therapeutic window, below which it doesn't work, above which it's toxic, right? So if the mutant selection window falls within the therapeutic window of the drug, you've got yourself a deal. You go to the high end, you kill off everything, all the susceptible organisms, all the mutants, and you prevent the development of resistant organisms. Or you could go very low, killing off most of the susceptible organisms, stopping the infection, making the patients clinically better, accepting that you didn't kill everything, but the patient's immune system will take over and eradicate the rest of the infection. So there's a low-dose strategy that does not promote the development of resistant organisms, and there's a high-dose strategy which prevents the development of resistant organisms. Everything in between is called the mutant selection window, where you are selecting for mutation and selecting for antibiotic resistance moving forward, and is what we want to avoid. So you have low dose and high dose, and you want nothing in between if you can help it. Now, for every bug and every drug, there is a different mutant selection window, and they have to be studied independently. So in this case, you would have to look at C. acnes and doxycycline, C. acnes and minocycline. You would also want to look at the other organisms on the skin that also have their own mutant selection window. So just because, I'm making this up, doxycycline works to suppress P. acnes on the face, what is it doing to strep? What is it doing to staph? So maybe it's doing a nice job killing the C. acnes, but it is promoting the development of resistant organisms of staph and strep. So you have to look at all of them in order to recognize the target organism that you're trying to kill, as well as the off-target organisms, the collateral damage that you might be doing. You have to look at their mutant selection windows as well. So moving forward, where this all came from and where we're going with this is that we have a lot of new medications coming out that are antibiotic in nature, and we're going to be applying them to the skin. We've already lost erythromycin, and we've lost clindamycin, as they no longer work really to kill P. acnes on the skin. And we don't want to lose any more antibiotics. So with these new antibiotics coming out, if we could use a high-dose strategy on the skin so that we didn't develop resistant organisms, wouldn't that be lovely? We're already doing it. Nobody thinks about it, but we're already doing it. We use antifungal agents all the time. We use antifungal agents in such a high concentration, 500 times higher than the MPC for those fungi, which is why we don't ever see the development of resistant fungal elements. You can use the same antifungal agent for the rest of that patient's life, and they will respond throughout their lifetime.
Interesting.
We also use the low dose strategy when we utilize anti-inflammatory dose doxycycline for the treatment of rosacea and maybe acne as well, where we're staying well below the minimum inhibitory concentration for the bugs that exist on the skin.
And C. acnes is the target then?
C. acnes would be
That's
the
just
target.
for me to know.
Right.
Yeah.
And well, actually, one of the reasons why we're using anti-inflammatory doxycycline for rosacea is because it's anti-inflammatory, not because it's killing organisms. So in this case, it's below the MIC for any of the known bugs on the surface of the skin.
And where do doctors get this information then, or prescribers? Is it in the label, or where?
Well,
this
that's
may
the
not
problem.
be included. I was just
This
curious.
is in some ways theoretical because we don't know the mutant selection window for C. acnes with all of these various antibiotics and staph aureus and strep pyogenes on the surface of the skin. Those are yet to be determined. What has already been determined are crucial infections with crucial antibiotics. So they've looked at moxifloxacin and strep and levofloxacin and staph. So those have been ascertained because those are crucial health-related mutant selection windows that need to be identified. So we're waiting to find out about the ones that are more pertinent to acne and rosacea.
So it's a good concept to become familiar
Yes.
with it and cover at this point.
Yes, and time will tell. But it's a whole new way to evaluate antibiotic resistance that hadn't occurred to us before. And maybe if you use the right concentration of a drug, maybe it's okay to be using a topical antibiotic on the skin without including benzoyl peroxide to prevent the development of resistant organisms, which is where this all came from, because patients don't like using benzoyl peroxide because it bleaches fabric. and it stains, and there are numerous reasons why benzoyl peroxide, although a wonderful drug, has a lot of baggage along with it.
We also caught up at Hawaii Derm with Dr. Jashin Wu of the Dermatology Research and Education Foundation in Irvine, California. Talking with MD Edge reporter Bruce Jansen, Dr. Wu explains how to choose the right oral agents for hyperhidrosis.
You like turning to the oral agents earlier than the International Hyperhidrosis Society guidelines would suggest. Why is that?
So the reason I do that is because I'm a medical dermatologist, and I actually don't have some of these other devices out there, like the Dry device. I don't have that in my office. And I actually have used a lot of the oral agents, the Robenal, for example, the oral medication. I've used that even as a resident. And so when you have exposure to a medication when you're in training, you tend to use it a little bit earlier. It's much easier, or much higher in your treatment algorithm. So I think that's one of the reasons why I'm a little bit more comfortable using it a little bit earlier on in my treatment algorithm.
What's your preferred oral agent?
Glycopyrrolate, or Robenal is the trade name.
Okay. And what kind of dosing do you prefer?
So it comes in 1 or 2 milligram tablets. So I usually prefer the 1 milligram tablets, mostly because it's easier for patients to self-titrate up. So usually I have them do 1 milligram twice a day. I'll have them do that for the first week or so, and then every week after that I have them increase by 1 milligram. So week number 2, for example, would be maybe 3 milligrams total. So maybe 2 in the morning and maybe 1 at nighttime, for example. Do that for this full second week. And then the third week, maybe up to 2 milligrams in the morning and 2 milligrams at nighttime. So then basically I have them say, okay, just get a sense of how well is the hyperhidrosis doing and how the swelling is doing. Maybe to start expecting to have good improvement around 4 to 6 to maybe 8 milligrams total per day. And that's when you can slowly hold steady and not necessarily increase the medication dose anymore.
And so that would be ongoing therapy,
right.
Long term.
Right, so obviously this is kind of a lifelong disease. They're not necessarily going to improve over time. So if they hit 5 milligrams is their sweet spot, and they just have them continue on that. And then maybe you can have them take the 2 milligram dosing, so they just take less pills overall. So they take 2 milligram, or a 2 milligram and a 1 milligram in the morning, and then a 2 milligram pill at nighttime. So just to reduce the total number of pills per se.
You presented some really, let's just say, disturbing data about mydriasis.
Yes.
Accidental emergency room docs urging brain surgery.
Yeah.
How often does that complication of therapy occur?
So in the data there, I think we showed maybe about 10-15% of patients will have the mydriasis, unilateral usually. So yeah, it can be a concern. So I think the most important point is that patients need to be educated that they need to wash their hands very well after they apply it to the affected areas, typically the armpit area. But even if they wash their hands well, they're probably going to accidentally transfer it to their face. As I mentioned kind of on the panel, studies have been shown that we humans touch our face 100 times a day. So maybe you just accidentally scratch an armpit, and then you scratch the eye area right after that, and then you accidentally transfer it, and then you have medication in your eye, and then you're getting this mydriasis. So, and then again, if they are educated that this is a potential side effect, have their friends and family be aware, so that if they actually see it, don't go ringing the alarms and go into the ER. And then of course, once you go to the ER, anything can happen. The doctor's going to say, "Oh crap, this is intracranial bleed or whatever, a tumor, and we need to go to the OR now," and that would be a disaster, obviously.
Yeah, for excessive sweating.
Right, exactly.
Brain surgery is a radical solution.
So in theory, even if you took the anticholinergic medications by mouth, you still could get the mydriasis. It might be more likely to be bilateral, though, just because it's a systemic agent.
Yeah. And do you typically give the topicals, either the cloth or the antiperspirants, a try before going on to the
yeah,
oils?
I definitely give those first. It's more of a second or third line agent for me using the pills, because obviously patients rather use something simple. But I mentioned before, say they have multiple spots, they have armpits, hands, and feet. So the cloth, that's only approved for the armpits.
Mm-hmm.
And obviously to apply it to all 6 areas potentially with a cloth, those are obviously not FDA approved, and so it might be hard to get covered by the insurance. But even if you got it covered, to put it in all those 6 areas every day might be difficult. So that's why another reason I kind of like the pills.
Sure. It's labor intensive too,
That's right.
topical applications.
Right, and then how are you going to wash your hands, obviously, when you put on your palms? I mean, that's...
Yeah.
You're washing off the medication.
You're headed from a psoriasis.
Exactly, that's right.
Probably bilaterally.
You're exactly right.
Dermatology Weekly will be right back with Peer-to-Peer after this message. Welcome back to Dermatology Weekly, the official podcast of MD Edge Dermatology. I am Nick Andrews. It is now time for Peer-to-Peer with Dr. George Han and Dr. Jashin Wu.
Today we're talking to Dr. Jashin Wu about phototherapy for psoriasis. Dr. Wu is the founder of the Dermatology Research and Education Foundation in Irvine, California. Thank you for joining us today, Dr. Wu.
Thank you, Dr. Han and Hughes, for having me speak today.
Great. So why don't we jump right into it? Let's talk a little bit about the basic science and the basics of phototherapy. So how does phototherapy work to provide benefits for inflammatory skin diseases such as psoriasis?
Sure. So I'm going to focus a little bit more on narrowband UVB. That is the major type of phototherapy that we tend to use in the dermatology world. So phototherapy acts by three major pathways. The first one is alteration of the cytokine profile. Psoriasis is thought to be a T-cell mediated inflammatory process driven by overexpression of certain cytokines. Phototherapy reverses this cytokine profile, shifting the immune process towards a counter-regulatory T-cell and away from inflammatory cells. The second major pathway is through apoptosis. So apoptosis, of course, is programmed cell death, and this is a key process in which it selectively targets a variety of relevant cells such as keratinocytes and lymphocytes, some of which also have relevance in vitiligo. The third major pathway is UV-induced immunosuppression of epidermal Langerhans cells, which results in reduced numbers and density of Langerhans cells. This in turn reduces inflammatory signals such as inflammation and other cytokines. And this also can be seen in broadband UV sunlight exposure.
Great. That's a very nice and concise explanation of the multiple pathways that phototherapy helps to ameliorate the inflammation that we can see with psoriasis, but also, as you mentioned, other inflammatory dermatoses. But one interesting question is, what are the advantages of phototherapy versus other therapies that we might be thinking about?
So phototherapy has some advantages. Certainly, if a patient has failed a topical treatment, but they may not be interested in systemic therapy, they don't want a biologic or they don't want an oral therapy, phototherapy still is a good option for these patients. In particular, I like it for patients with moderate disease. So moderate disease would be between 3 to 10% body surface area.
Okay. And just kind of as an extension, since you were a co-author on the new guidelines from the AAD and the MPF on phototherapy for psoriasis, which patients do you generally consider candidates for phototherapy or good candidates for phototherapy under those guidelines?
Right. So I was fortunate enough to be part of those national guidelines. So we do say that phototherapy serves as a reasonable and effective treatment option for patients requiring more than topical treatments, but also wishing to avoid systemic medications, or if they simply seeking an adjuvant to a failing regimen. So certainly, as I mentioned before, if they failed clobetasol, which is one of the strongest published steroids we have available, and they don't really want a systemic agent, they're kind of worried about side effects potentially with a systemic agent, then phototherapy is certainly a good option. It can also be used in combination with other therapies, of course. You can still use it with topical agents. You can use it with oral agents, in particular something like acitretin. That's probably the best combination with narrowband phototherapy and acitretin. But you can certainly also use it with one of the biologics as well.
Okay. And are there certain patient populations that you might think of reaching for phototherapy for, such as patients with comorbidities or pregnant patients or any other categories?
Yeah, that last category is very important. If there's someone who's pregnant, many times patients are worried about side effects potentially onto the baby. So most systemic agents, in theory, could cause a problem. I think the biologics maybe less so, especially with something like certolizumab. But still, many patients are still worried about side effects. So phototherapy is a very good option for these patients who happen to be pregnant and have psoriasis.
Okay, thank you. I think that's a great point. You mentioned earlier a little bit about using phototherapy in combination. I was hoping we could delve into that a little bit. So can phototherapy be used in combination with other therapies according to the guidelines?
Yes, so we reviewed some of the literature in terms of combination with some of the topical agents, and interestingly, vitamin D analogs such as calcipotriol in combination with narrowband phototherapy actually did not seem to have much of an improvement when it was phototherapy by itself versus a combination with calcipotriol. Tazarotene is another topical agent, and that also seemed to have some mixed data. It did not seem to actually have much improvement with the combination of tazarotene and phototherapy. Although another study did seem to show that maybe there's some improvement with tazarotene and phototherapy. So it seems to be a bit of a mixed results with some of the topical agents. We did also look at the topical psoralen, more in combination with UVA, and so that can be more effective if compared to just UVA by itself. We do not recommend topical psoralen in combination with narrowband phototherapy, however. In terms of oral agents, methotrexate has been studied, and so methotrexate in combination with phototherapy could be used, but actually in one study there was actually no improvement with this combination compared to just monotherapy, phototherapy by itself, or with methotrexate monotherapy by itself. As I mentioned before, acitretin is probably the most important and most widely used combination therapy. In theory, phototherapy could increase the risk of skin cancer, especially if they have several hundreds of episodes of phototherapy. Acitretin, in theory, may improve the risk of skin cancer. So actually, this has a protective effect and also may reduce the number and length of phototherapy that's needed if they're on something like acitretin. Cyclosporin is something that we actually don't recommend in combination with phototherapy. In theory, cyclosporin and phototherapy in combination could increase the risk of skin cancers, so we typically do not recommend this combination. In terms of the biologics, there have been studies with some of the older biologics in terms of etanercept, adalimumab, and ustekinumab, and all of these have been shown that the combination therapy does seem to be a little bit more effective than each of the monotherapies by itself.
Okay, great. So certainly something to think about for those patients who are overall doing well but maybe need a little extra clearance. You did allude to this when you were speaking about the acitretin, but overall, what do you think are the risks and side effects of phototherapy, especially compared to the benefits? What are you somewhat wary of and cautious of?
Right. So the ones that we most worry about would be skin cancers, especially around the genitals. So we do recommend that patients have some genital shielding while they're getting phototherapy. We also recommend that they wear goggles so they do not increase the risk of cataracts. So as I mentioned before, the skin cancer risk, that's a bit controversial. Some studies indicate that if they have PUVA, oral psoralen plus UVA phototherapy, they could increase the risk of skin cancers. Skin cancer risk in patients treated with UVB, both narrowband and broadband, was correlated with the number of treatments received, although the calculated risk of malignancy was not significantly greater than that of the general population. So it's a bit of a mixed bag here as well. I would say narrowband phototherapy is probably less likely to cause skin cancers than PUVA, but certainly if they've had a prior history of skin cancers, I probably wouldn't be choosing phototherapy as one of my first-line agents.
Now, with regards to the administration methods, what in your mind is the best way to get people onto phototherapy in terms of logistically?
So there's different ways, of course. There's the narrowband phototherapy. That's typically more of an office phototherapy. So typically speaking, you have a narrowband booth in your office. And so patients would come in 3 times a week in general for the initial treatment. And then after that, once they're clear, I typically have them come in once a week or every 2 weeks or so as the maintenance dosing. Sometimes patients don't really want to come to the office that often, especially if they live far away, then it might not be feasible for them. So home phototherapy actually would be a good option for them. Sometimes the insurance carriers would actually prefer this. Sometimes, in my experience, they actually would not mind paying a couple $1,000s so the patient could get the home therapy unit, and in a way that can potentially prevent them from going on to a biologic, which may cost 10 times that amount over the course of 1 year. In particular, there's a new home phototherapy unit called the Clarify Medical System, and that one is a little bit different and potentially more effective for patients. I think it's also less likely to have side effects compared to the traditional home phototherapy units. I think with home phototherapy units, sometimes we worry that patients may be at a high risk for erythema or sunburns just because they're not really being seen by us or by the nurse that regularly. But with the Clarify Medical System, I think that risk is a little bit less likely to occur in these patients. And of course, there's other things as well. There's other modalities such as the excimer laser. That, of course, is a laser that is done in the office. So again, if the patients don't mind coming in 2 or 3 times a week initially, then that can also be effective for patients. I think PUVA is getting out of favor at this point just because of the effectiveness of the biologics and potentially more side effects with the oral Sorolin.
Okay, thank you. I'm kind of curious. You mentioned the Clarify medical system. I've actually not heard of that. Could you explain a little bit about how that limits the potential side effects and burns from a home unit? Is it auto-calibrated? What about it makes it safer in your mind?
So traditionally speaking, with home phototherapy units, you'll give a patient a manual, and it'll say, kind of describe how many minutes or seconds they need to be in the unit based on millijoules, and sometimes it can be very confusing for patients. So the nice thing about the Clarify home phototherapy system is that it's kind of a safe and controlled unit, and actually goes through an app as well. And so it delivers precise narrowband phototherapy light between the wavelengths of 300 and 320 nanometers. And it's connected to a smartphone application that enables the handheld device and provides feedback during treatment. And so that can be linked to the doctor's office so that you can actually look into the patient's treatments to see if they're getting too much or too little. And it actually has a good way to contact the patients when they're not in the clinic. This Clarify portal also calculates the dosing per the protocol, and it collects and stores the treatment. And actually it has some adherence data as well. So sometimes, as a downside, if you have a traditional home phototherapy unit, you don't really know if patients are getting the treatments. You can maybe get a rough sense because many times they'll need to get a quote-unquote a refill, and they can't actually get more phototherapy units until they come to see you, and then you call the system and say, okay, they need another 50 or 100 sessions. But here it actually is able to keep track of that adherence data and the self-report outcome measures. And it also keeps track of patient satisfaction and actually can also take photographs as well. So it's really quite a nice way to monitor patients remotely.
Thank you for that pearl, Dr. Wu. I certainly will keep that in mind for my patients. Actually, just recently, I had to go over with a patient the home phototherapy device, and it was just as you mentioned. They brought in this table with probably about 30 to 40 columns in it, and we had to figure out exactly how long they're supposed to stand in front of the light for.
Oh, yeah, and I've gone over that table with patients many times, and they just get confused, and then obviously they get a risk for a burn if they're giving themselves too much light. So I think something like this can kind of simplify the amount of light that the patient may need.
Definitely. And what you said about the cost, I think, resonates too, because as you mentioned, a few $1,000s. I've had some patients actually calculate the cost of their copays, and they figure by the time they finish the treatment course, they'll have paid the same amount anyway. So it's more convenient to have it in their own home. Right. Do you have any tips for getting the home phototherapy approved for your patients, though?
So most likely they will already failed a topical agent, so you can certainly mention that to them, to the insurance. So of course, you can kind of appeal to the insurance's sensibilities and say, okay, I want to put them on a biologic X, and that's going to cost you $20,000 to $30,000 a year. And that could be indefinitely, right? These biologics, they're not a cure, so obviously they've been on it indefinitely. But then if you're willing to pay for this home phototherapy unit instead, which is maybe $2,000 or $3,000, and that's just a one-time cost, maybe you consider that first before you switch them onto a biologic potentially. Maybe in the future, maybe when they get psoriatic arthritis, maybe they'll need that biologic. But if you can hold off on starting that biologic, even for just a year, that's significant cost savings to the insurance. And I think if you give them some argument like that, I think they would all be willing to buy the home phototherapy unit for the patients first before you start them on a biologic.
I believe also, if I'm not mistaken, some of the major phototherapy companies do have portions of their website where they offer some help and assistance and patient forms and things like that. So I think there certainly are resources out there, but the first thing is to really think about it for an appropriate patient, as you mentioned. So I think we ought to wrap up with kind of the long-term treatment goals and what to do for our patients, because as we know, all our patients like to know when they're starting treatment, when can I stop, or how can I stop, or what is the maintenance regimen like. So what do you think is a good maintenance regimen? You mentioned it a little bit, but could you expound on what an appropriate maintenance regimen for phototherapy is?
So in the guideline, we didn't really talk about drug holidays. We talked more about maintenance. So as I mentioned, we can have the patients come in once a week or every 2 weeks. Once they get down to that level, usually you do not want to increase the dose that certainly increases the risk of a burn. Usually hold steady or maybe reduce the dose by 20-25%. So in terms of drug holidays or light holidays, many patients actually kind of request that on their own. So for example, maybe in the wintertime when they're not outside, especially here in California, I don't know if there's much sun there in New York at this time of year in February, but even now we have good sunlight here in Southern California. So these patients, even though it is wintertime, they're probably still not outside as much. So they're just getting less natural light. So they would get phototherapy still at this point. Once it comes around to the summertime, then they usually want to stop and just go outside on their own and just have kind of their own maintenance with natural sunlight. And then once the fall rolls around and it gets less sunny, then at that point they may want to start coming in again, in which case they'll probably need the induction phase again. You usually cannot just put them straight onto the maintenance phase once they've been off of it for several weeks or months.
Okay, so take-home point is try to get them on a maintenance regimen, and if they do ask for a light holiday, probably okay, but we are going to start them off again on a low dose when they come back.
Right.
Okay, I think that was a great and informative discussion from the soup to nuts for phototherapy. So thank you for that informative discussion, Dr. Wu. Do you have any last comments for our listeners before we sign off?
I just want to stress the fact that phototherapy is still a viable option for patients. I know the press and the news is all about the biologics and the latest and greatest, but phototherapy still has a place for many patients, so don't forget about that.
Thank you, Dr. Wu. Thank you for your time, and thank you for joining us today.
My pleasure, George. Take care.
And that's it for this week's episode of Dermatology Weekly. Don't forget you can find previous episodes wherever podcasts are found. Be sure to catch every new episode of Dermatology by subscribing on Apple Podcasts, Google Podcasts, Spotify, Pandora, YouTube, or wherever you like to listen. For all of us here at MD Edge, I'm Nick Andrews. You're listening to Dermatology Weekly.